Welcome to the Health Beyond Research and Innovation Showcase for Fairfield Hospital. My name is Dr. Ramanathan Lakshmanan. I'm the Executive Clinical Director for Fairfield Hospital. I'm also the ICU Director and Senior Staff Specialist at Fairfield Hospital. I work across Southwestern Sydney network as an ICU specialist in Campbelltown and Liverpool. I'm the chair for today's event, and it is my pleasure to invite Mr. Rob Doyle to deliver the acknowledgement of the country.
Thanks very much. My name's Rob. I'm an Aboriginal man brought up on Darkinjung country. I claim my Aboriginal heritage from my mother's side of the family. So she's Cadagal Eora Nation, which is East Sydney on her mother's side, and Winninini, which is a very small community from the Northern Territory. And as a visitor myself, I acknowledge that we're meeting largely on the Darug Nation and our various sort of mobs that live on there. So I'm coming from a Darawal area, and I think it's Kerbrogel, that's the Fairfield Nation that we're all meeting on. And I'd just like to acknowledge those traditional owners and recognize that part of acknowledging the custodians of the land is recognizing that we have a responsibility to tread lightly and to sustain Aboriginal voices and Aboriginal leaders. In the lead up to the voice that's coming up, I'll just let everyone know I think it's going to get rough for Aboriginal people, because some people are pretty not happy about that. And I think that we in the medical field, in the health field, in the research field, we all have some part to play in making sure that Aboriginal people can be safe and feel welcome in their own lands. So thanks for this opportunity just to have a bit of a yarn with you, and I invite to have a good spirit as we go on talking about the rest of the conference. Thanks.
Thank you, Rob, for delivering the acknowledgement of the country. I'd like to now invite General Manager of Fairfield Hospital, Ms. Paul Crow, to deliver a speech.
Hi, thank you very much. Hopefully we'll get to the exciting stuff pretty soon. I'm here again to also acknowledge the traditional owners of the lands on which we meet and pay my respects to elders past and present. Always was, always will be Aboriginal land. So welcome to the Fairfield Hospital Research Showcase. I'm Paul Crow, the General Manager of Fairfield Hospital, and it's my great pleasure to be here with you today to hear some really big ideas from a small place in Western Sydney, in southwestern Sydney. I'd like to begin by acknowledging the researchers that you find here with you today. Ram, as he introduced himself before, thank you very much, Ram, for the introduction. For Seema Radhakrishnan, who's a staff specialist in rehab, who works at both Fairfield Hospital and also at the university. For Ritesh Chamuria, endocrinologist and PhD candidate. Dr. Fernan Gamel, who is an orthopaedic SRMO at St George and Sutherland Hospitals, as well as a PhD candidate within New South Wales. Ms. Kimberly Rayner, who's an exercise physiologist, and Joanne, her counterpart, Joanne Harvey, who work closely together as CNS at Fairfield Hospital. For Dr. Gayatri Bazunda, Journal and Geriatric Medicine Specialist at Fairfield Hospital. Mr. Thomas Hwang, who's a physiotherapist at Fairfield Hospital, and Dr. Leanne Chen, ICU anaesthetics trainee, Fairfield Hospital, and all of you that enjoy big ideas, all researchers and distinguished guests joining nationally. We've got a really outstanding program here today. Some really great ideas to share with you and some really good research points. It really shows the commitment of the LHD, the Local Health District, to research as it's flourishing in southwestern Sydney. And I'm proud, and we're all proud of the commitment of our LHD staff in enhancing patient care through their quest for discovery and innovation. The key focus today is the commitment of research and innovation and education, which is a major foundation of the LHD and its strategic plan. And one of the key elements is the plan is ensuring we attract people that you'll hear from today who retain and nurture emerging and expert research in all disciplines. And I'm excited to see how these people that you are here from today, and I get to see them every day, actually implement this research in their work. So that's really exciting for me as well. So the Health Risks Beyond Research and Innovation Showcase has been a series that you've probably attended, and this time it's Fairfield's turn. It's presented by our district and our valued partner, the Ingham Institute for Applied Medical Research. It celebrates the advances in health research, innovation and technology in southwestern Sydney. We've been delighted to welcome distinguished local and international speakers to our seminars, and as we present our groundbreaking research to our community in the world, we're thankful for them attending. The research committee at Fairfield Hospital particularly was restructured a few years ago to make it multidisciplinary, where everybody's contribution was valued, and research representatives across disciplines at Fairfield Hospital contributed towards research improvement. The key focus was supporting novice researchers, and some of them you'll hear today, via courses and education material from the Southwestern Sydney LHD Research Directorate and their partner, the Ingham Institute. Fairfield Hospital is the location of one of the busiest hand surgical centres in the state, as well as an orthopaedic centre. And Whitlam Joint is that orthopaedic centre. Our aim is to promote research amongst young clinicians during the annual orientation program, which includes a session about introduction to research and innovation, along with the steps to navigate various ethics application processes, which I'm sure are hurdles that you'll all enjoy running through as you get to your great ideas. Thank you once again for joining today's seminar on this important area of research, and particularly for my area of concern, Fairfield Hospital. I particularly thank the Fairfield Hospital Academic Unit for presenting the seminar. I also thank you for your commitment to delivering cutting-edge healthcare for your patients. And I hope you all enjoy and be informed and inspired by the advances in this critical research area, which will shape the care we provide in southwestern Sydney and also the world. So let's hear some really big ideas from a really small place in southwestern Sydney. Thank you.
Thank you, Paul, for giving us an inspiring speech. I'd now like to invite Dr. Seema Radhakrishnan to present a topic on post-hip fracture care for migrants and refugees. Thank you, Seema.
Hello, I hope you can hear me well. I'll just share my screen. Okay. All right, so the Fairfield Hospital Ward 1B that I work in, we about 30 to 40% of our inpatients receive rehabilitation following an osteoporotic fracture, usually hip fracture. Although the age standardized rate of hip fracture is falling in Australia because of the sheer number of people that are aging, the total number of hip fracture is set to get bigger and bigger, with an increasing proportion of patients requiring rehabilitation. So in terms of assessing the quality of the hip fracture care, we do have the national standards. There are about 7 standards that that involves adequate assessment in the ED, along with pain relief, surgery within 48 hours of presentation, orthogeriatric model of care, starting mobilization from day one, having starting the osteoporosis prophylaxis, as well as having a personalized individualized care plan that will help with transition into the community. So we have some quantitative measures we do collect, but we don't really know a lot about consumer expectation, which can change depending upon their orientation to the health system, interaction to the healthcare team, as well as these changes that happen through transitions of care, as seen in the previous slide. So next slide, please. So we did 2 studies to look at rehabilitation care in hip fracture patient. The first one was to look at compliance with Evolve top 5 recommendations. So this is a part of Choosing Wisely program, put forward by the RACP, the Royal College of Physicians, and it's one of the most important choosing wisely recommendation from a rehabilitation point of view is not to discharge patients or to discharge them with an osteoporosis secondary prophylaxis. So we wanted to look at how well we were doing in that respect. We did a retrospective study of all patients admitted to Fairfield Rehab Ward 1B between July 1st of 2018 and June 30th, 2019, so over a 12-month period, and we collected data at 3 points on admission and on discharge, as well as 12-month post-discharge. So because most of our patients remain within the Southwestern Sydney LHD, we collected the 12-month post-discharge data from the EMR, as well as through My Health Records. Next slide, please. We collected demographic information, including language, age, gender, comorbidities, previous osteoporosis treatment, the level of vitamin D on admission, as we felt it was important because if the vitamin D is not replenished, then the patients are not really started on anti-resorptive therapy, which has the best evidence to reduce the fracture risk. We also looked at osteoporosis treatment on discharge and any fractures in the 12 months post-discharge, as well as whether they were on treatment at the end of 12 months. Next slide, please. So overall, we had 49 patients going through our rehabilitation facility in a year. 13 of them had vitamin D less than 50 on admission. So these patients would not be put on a secondary prophylaxis with an anti-resorptive therapy because of the low vitamin D levels. The mean age was 80. There were more females than males, which is what we would expect in osteoporotic hip fractures. About 50% of them had multiple comorbidities. 50% of them had less than 4 comorbidities. Most of them, it was their first osteoporotic fracture or diagnosed osteoporotic fracture. We don't have a lot of information. A lot of the vertebral fractures are undiagnosed in general population. We had about more than 50% were from a culturally and linguistically diverse background. In terms of being on osteoporosis prophylaxis, you can see on the first slide, most of them on admission were not on anything, including vitamin D or calcium. But on discharge, the number of patients on vitamin D and calcium supplementations did improve. However, those on anti-resorptive therapy did not show an improvement. So most of the patients were discharged from on vitamin D and calcium, but not on anti-resorptive therapy. And that number did not, so that was far less than the number of patients who were vitamin D replete. Next slide, please. On the 12-month review, additional 3 patients had started on anti-resorptive therapy. One had stopped them due to stop the anti-resorptive therapy due to side effects. 3 of the patients were lost to follow-up. 1 had moved interstate, and we did not have access to their medical records. And 2 of them did not have a My Health record. One of the patients in the cohort of 49 presented with the fracture of the opposite hip. We found no correlation between the language spoken at home and if the patient was on secondary prophylaxis. Now, moving on to the next slide. The second study was done through Braeside Hospital at Fairfield. We work very close with Braeside Hospital, and any patient who require more than 2 weeks of inpatient rehabilitation following post-hip fracture get transferred to Braeside. We did a retrospective audit of all patients admitted to hip fracture rehabilitation in 2019 at Braeside Hospital. And our aim was to explore fractures that affected length of stay in rehabilitation post-hip fracture surgery. The data sources included Australian Rehabilitation Outcome Centre data, which all the rehabilitation facilities in the country, and New Zealand, submit, so that there is a comparison between both private and public rehabilitation facilities, and there are benchmarkings on outcomes. We also use the medical records to collect some of our data. Overall, about 43 patients had a post-hip fracture rehabilitation in that 1 year period. In terms of the length of stay, the average length of stay was 27 days, and the national average varied between 15.6 and 27.8. So we were sort of within the benchmark. Next, please. Next slide, please. We collected a number of data which were patient-related, like age and gender, admission FIM, discharge FIM, and pre-morbid living status. So FIM is it's an outcome tool that we collect both with regards to their motor function as well as cognitive function. So it has two parts. We also collected fracture-related variables like length of stay in acute care, surgical intervention, and complications in rehabilitation, along with environmental factors, including services at home, need for home modifications and equipment. We split the group into two, one whose length of stay was less than the average, and the other group length of stay was more than the average. And we used independent t-test and t-squared test to see if the statistically significant variables that affected the length of stay. Next, please. So overall, we found three variables. One was the admission FIM. So if you have higher FIM on admission, it means that your functional capacity is much better. So people who are better in their mobility and cognition, they had lesser length of stay. The other factors affecting the length of stay was pain, as well as medical factors like poor blood pressure control, which could be related to, in fact, the pain, because having uncontrolled pain can cause increase in blood pressure as well. So where do we go from here? Next slide, please. So in terms of the first study, we contacted, so Liverpool, so all of our hip fracture patients are transferred from Liverpool Hospital after their surgery because we are not a trauma center. And they have a fracture liaison service with a coordinator, as well as a refracture prevention clinic. So we contacted that service and see if we could do anything to improve the referral for hip fracture patients. And the outcome of that communication was that they prioritized all the hip fracture patients when they've transferred to Fairfield, and they were given an appointment on discharge from Liverpool before coming into Fairfield, before they were transferred to Fairfield. So that did improve in change of practice. In terms of study 2, more attention was paid to their pain management, both in the subacute setting at Fairfield as well as at Braeside. What we found out, what we really don't have a hand on is about the qualitative or the experiences of the patients that go through the hip fracture pathway, as to whether there is a difference between the patients who are from a non-English speaking background, whether they present in the same or they did not attend rates in the refracture clinic is different to for an English speaking population. So we are in the process of through our network trying to organize do a qualitative study to look into all these, which includes variation in cares and barriers to the secondary prophylaxis through implementation science methodology. Thank you.
Thank you, Seema, for wonderful presentation. We've got a few questions online that if you could answer, that would be great. And for people who want to ask questions, please put it on the QA section rather than the chat, so we could track and ask those questions as required. So Seema, according to ACI model of care, osteoporotic fracture prevention, apart from osteoporosis, falls prevention is another important arm of management. Is there any falls prevention measures in your study?
Hello, Taitek. No, we did not conduct that as a part of the study, as it was a very small audit, and we did not look into that. but definitely that the falls prevention and the compliance with the individualized care plan to reduce falls and fractures on discharge from rehabilitation is being looked at, or we're planning to look at in a different study. So yeah, no, that was not looked at in this particular study. It was mainly what happened in rehabilitation.
Thanks, Seema. I'm gonna, there are two more questions, but I'll just ask one last question. How did you gain research consent for My Health record data usage?
So I just applied through the ethics committee, and I explained that they did not have any concerns about that. So it was through ethics.
Sure. Taitak will answer the other question in a separate section, or we'll answer through, we'll get Seema to answer those questions later. Thanks, Taitak. Thanks, Seema. I'd now like to invite Dr. Ritesh Chimoria to present a study on feasibility of a partial meal replacement weight loss program for people awaiting arthroplasty. Thanks, Ritesh.
Thank you. Hope everyone can see my slide and hear me properly. Yeah. Yeah. Good afternoon, everyone. I am Ritesh Chimoria. And before starting my presentation, I'd like to acknowledge the traditional owner of the land on which we meet today, Daruk and Darawal, and the elders past, present, and future. I'd also like to thank the organizing committee for providing me this wonderful opportunity to present a finding from my study. And on behalf of the research team, I'll be presenting the finding from the partial meal replacement weight loss program for people awaiting arthroplasty. We sought to evaluate the effectiveness and feasibility of 12-week partial meal replacement program. As obesity is a very complex condition attributing to numerous chronic conditions, including cardiovascular disease, type 2 diabetes, non-alcoholic fatty liver disease, and osteoarthritis. And there are numerous studies suggesting a need of a chronic disease model of care in order to manage and prevent those numerous associated disease, in addition to improvement in health-related quality of life. Now, according to Australian Orthopaedic Association National Joint Replacement Registry, over half of the people undergoing total knee or total hip arthroplasty in Australia have obesity, which would be somewhere around 48,000 people. And at Fairfield Hospital, the incidence of obesity among those undergoing surgery is around 65%. That's based on our local data. Now, obesity is again associated with greater risk of complication, such as lower absolute recovery in mobility and patient-reported pain and function, as well as higher cost of care following arthroplasty. So acknowledging those associated risks, weight loss is recommended prior to arthroplasty in people with obesity. And there are very limited evidence in relation to the best method of achieving a clinically meaningful weight loss in people with obesity prior to surgery. And this again becomes very scarce when we're talking about effectiveness of diet-based weight loss in improving patient outcome. So our study aimed to assess the feasibility of 12-week partial meal replacement or PMR weight loss program for people awaiting arthroplasty. So it is a prospective pilot cohort study where the participants were recruited through Fairfield Orthopedic Hip and Knee Service for people who are awaiting arthroplasty. And the intervention was provided by Southwestern Sydney Metabolic Rehabilitation and Bariatric Program at Camden Hospital and remotely via telehealth. So the intervention in the study was 12 weeks of partial meal replacement plan of 1,200 calories per day, which included 2 meal replacement shakes and a third suitable meal option. Along with that, we had online education session, which was delivered via Zoom by a dietitian at the start, 6 and 12 weeks, along with one-to-one teleconsultation at week 2, 4, and 9. Similarly, patient also had access to structured PMR app as a form of digital behavior change, a program which included weight tracking, nutrition educational content, and behavioral strategy to support weight loss. And we can see the app in the screen as well. And this app has been developed by the provider of meal replacement shake. Now, the eligibility criteria for this study, participants were being in a wait list for arthroplasty at Fairfield Hospital and having body mass index equal to or greater than 30. Patients who were unable to understand spoken or written English or currently participating in any other weight loss program or had recently lost more than 5 kilograms in last 3 months were excluded. Along with that, patient who had bariatric surgery within the last 2 years or patient taking insulin were also excluded from this study. Now, in terms of data collection, we've collected data at 2 time points at the start, baseline, and 12 weeks. The demographic data and medical history were collected at baseline, whereas anthropometric data, most importantly, weight along with data for medication use or any health events were collected at both time points. Similarly, changes in risk of psychological distress was assessed using K10 score. Along with that, we collected index joint symptoms via Oxford Heap and knee questionnaires. Similarly, we have also collected well-being and lifestyle through a questionnaires at both time point. Similarly, we looked at willingness to pay at the both time point and acceptability of program at 12 weeks. As the intervention was conducted during harsh period of COVID-19 restrictions, the weight were recorded by patient on their scale at the same point of the day and reported back to the research team. Now, the self-reported data were cross-validated by one of the following means, sending the daily log of weight along with images of weighing machine to dietitian. And again, it was cross-validated using clinical data at Fairfield Hospital and also using the logs in the PMR app. So 182 patients were approached and tried contacting. We're unable to contact 62 patients on multiple attempts, and 13 patients had already underwent surgery, so we did not contact them. So we had 107 patients who were contacted by team members and explained about the service and the study. 35 patients refused to participate. Most common reason were not being interested in doing a meal replacement program for weight loss, or were involved in a self weight loss program, or were unable to join remotely, such as were unable to join via Zoom or app being too technical to join remotely. And at last, we had 72 people who were interested in the program, of which 43 were excluded based on eligibility criteria. Most commonly, 17 patients had recent weight loss of more than 5 kilograms, 12 were unable to understand written or spoken English, and 7 were on insulin. Now, at last, we had 29 patients who consented and 26 started the meal replacement program. And during the course of 12 weeks, there were 4 dropouts, and lastly, we had 22 participants who completed the program. So looking at these figures, we can say that around 27% of people who were contacted consented at the end. The mean age of the participant was around 63 years, with majority being Caucasian and female. The common comorbidity among the cohort was hypertension, as more than half of the participants had hypertension. Similarly, type 2 diabetes, dyslipidemia, obstructive sleep apnea were also common comorbidities. And the mean baseline weight was slightly over 105 kilogram, and giving us a BMI of 39. Now, all of the participants who have completed follow-up data collection, as well as the programs were included in the analysis. After 12 weeks of PMR, there was significant weight loss of over 6 kilograms. And with most of the participants, which is around 15 of 22 total, achieving at least 5% weight loss. Now, in terms of biochemical changes, statistically significant reduction was observed in HbA1c and LDL level. There was minimal changes in index joint symptoms, which again was assessed using Oxford knee and hip score. The changes in K10, EQVS, and WHO5 well-being index were also very minimal. However, the self-reported changes in readiness to lifestyle behavior change questionnaires indicated that there was increased in proportion of people who consumed less sugary food and carbohydrate in 12 weeks, and proportion of people making oneself stronger in terms of readiness to change physical activity also increased. Lastly, the proportion of people who reported readiness to change weight and trying to reach one's best weight was increased from baseline to 12 weeks. Now, in regards to acceptability of the program, the participants were asked how much they would be willing to pay for the meal replacement. The average acceptable value reported by the participant was around $69 per fortnight. Now, in spite of PMR being delivered remotely, the program was feasible and well accepted by the participants. Moreover, throughout the study period, no adverse events were reported. So the major three take-home messages from my talk is the study finding demonstrates that significant weight loss, which is over 5%, is achievable in people awaiting arthroplasty following 12 weeks of partial meal replacement weight loss program. And also it lowers the HbA1c and LDL, which was observed in our study. And in terms of willingness to pay for meal replacement, the average acceptable value reported was $69 per fortnight. And despite the intervention being conducted remotely during COVID-19 restrictions, the PMR program was feasible and well accepted by the participants. Lastly, I'd like to acknowledge all the study participants, Carol Flickskens, Elizabeth Stelino, Sanya Agu, and Whitlam Orthopedic Research Center, Ansmas and Counterweight UK for their support in this program. Thank you. I would be happy to take any questions now or contact us via email in future.
Thanks, Ritesh. That was a very relevant topic for Fairfield with the community out there. We have a minute, and if we can see if there's any questions online. There's no questions online. If there's any questions, please do email it across to us and we can clarify with Ritesh. Thanks for your presentation, Ritesh.
Thank you.
So now I'd like to invite Dr. Fakan Janel to present his topic on dose of opioid use pre-surgery predicts outcome at 6 months following primary unilateral knee or hip arthroplasty for osteoporosis. Thanks, Dr. Janel.
Hey guys, thanks for having me and giving me the opportunity to present this talk on behalf of my very well supported extensive study team. My name is Furkan. I'm an orthopedic SRMO at St. George's Southern Hospitals, as well as a PhD candidate at University of New South Wales.
Furkan, sorry, yeah, that'll be good.
Can you guys see that now?
Yes.
Awesome. So firstly, these are my declaration of interests. So, as we know, in Australia and other countries around the world, we're actually experiencing an opioid crisis, where there is hospitalizations and deaths related to opioids have steadily increased since the year 2000. However, there is some good news and there is some light end of the tunnel, in that since 2015 to 16, post-opioid related hospitalizations have gradually been decreasing. Looking through the research and the data available, chronic use of opioids pre-arthroplasty is associated with increased risk of persistent opioid use after joint replacement surgery. There's increased risk of patients being readmitted to hospital after their surgery, and there's increased risk of post-operative outcomes, including those with surgical site infections or those needing revision arthroplasty. In a US meta-analysis, it was calculated that roughly 24% of patients who are undergoing primary total knee or total hip arthroplasty are chronic opioid users before surgery. However, in our Australian context, or in regards to any Australian studies, there's actually a few studies that examined the extent of opioid use prior to arthroplasty. And we're actually unsure whether preoperative opioid use predicts the post-operative outcomes or complications. So in our objective of our study was, in the Australian context, we aim to determine, firstly, the proportion of those patients who are having total knee or total hip arthroplasty who are using opioids regularly, which is on a daily basis before the surgery, and whether the opioid use before surgery predicts complications and readmissions up to 6 months following surgery, and patient-reported outcomes up to 6 months following surgery. So this was a retrospective study where we had utilized two separate clinical databases, which is the ACORN database as well as the OACCP database from Southwest Sydney. And these two databases were firstly cleaned and then merged on a patient level. So data between the two databases were linked per patient. And the participants of the study included those who had surgery between 2013 and 2018, based at patients who had surgery at Fairfield or Barrow hospitals in the Southwest Sydney local health district. And looking at these two databases, there was roughly 3,500 patients in these two databases prior to them being merged. In regards to our primary exposure variable, it was a dichotomous outcome, is where the patients last recorded opioid use prior to arthroplasty. So they would have been asked at either 12 weeks of OACCP assessment, 26 weeks or 52 weeks, whether or not they're taking opioids. And if it was a yes, we deemed them to be using daily opioids regularly prior to surgery, or if it was no, we considered them as non-opioid users. The primary endpoint of interest was a composite outcome where we combined complications and readmissions up to 6 months following surgery. And this came under one outcome as adverse events. And the secondary endpoints of interest were up to 6 months following surgery, what the Oxford scores were, either whether it was hip or knee score, and the global perceived improvement following arthroplasty. So this will be patients who rated themselves feeling much better at the end of 6 months after having the surgery versus other responses. So when we completed data linkage of the ACORN and OACCP databases, this analysis included 1,183 participants. And we found that within our cohort of patients, there was roughly 30% of patients who were regularly using opioids prior to arthroplasty. When we look at the characteristics between the two groups, we found that those who were opioid users were slightly younger, were slightly more heavier as well. And there was a disproportionate, so there was more people in the opioid users who were actually having a hip replacement compared to those who are non-opioid users, so high proportion of hip replacements in that category. And we also found that the Oxford scores prior to surgery was also lower than those who were using opioids. When we have a look at the spectrum of those with their comorbidities between the two groups, it was interesting to see that the opioid users had an increased risk of those who are suffering from depression and anxiety, and those who also had a higher proportion of those who were suffering from lower back pain. We did an unadjusted analysis where we tried to determine whether preoperative opioid use related to various outcomes, as I described before. When it came to acute length of stay or discharge to inpatient rehab, there was no association between the two. When we looked at the adverse events, those were complications or those with readmission rates up to 6 months. We found that if we look at the context of significant acute adverse events, post-discharge significant events or total, there was no association between the two. Oxford scores at 6 months following surgery was not significant. What was interesting is that when we have a look at the EQ5D VAS scores, where patients report their overall health on a scale from 0 to 100, 0 being worst health and 100 being the best health, there was actually statistical significant difference in that the opioid users were worse in rating their health compared to the non-opioid users. And same as that, global perceived improvements as much better or similar between the two cohorts. And thus, we took the research a bit further, and we wanted to control for covariates that will actually influence these rates and control for certain variables. And we found that for those opioid users, again, the only small but significant difference was the EQ5D VAS score at 6 months following surgery. So the conclusions that we derived from this study is that preoperative opioid use was high amongst our cohort of patients when we are doing the analysis, and was not associated with increased risk of adverse events post-operatively. But as you realize, when we're doing this analysis, those the outcomes we were looking at was dichotomous of whether or not patients were using opioids, either yes or no. So further research needs to be done to assess whether the relationship between the amount of people, the amount of opioids that were being used by the patients before surgery, and whether this has any association, and whether this has any association with post-operative adverse events. That's it. Thank you.
Thanks, Birkin. That was a fantastic presentation. We've got a couple of questions on the chat line. What was the OMID average of opioid users?
Yeah, so that is one of the limitations of the CMA of our study. The ACOR, the OACCP database, which actually had that data, didn't actually record the amount of what patients were taking, which opioids they were taking, or the amount that they were taking. So we couldn't actually stratify between those who were taking high amounts of OMIDs versus those who are taking low doses of opioids. So that is a limitation of the study, and that's where the further research should be taken. But based on the context of the study that we actually conducted, we just had to use it as a dichotomous outcome, unfortunately.
No, fantastic, because that was the second part of the question anyway. Was the difference between high and high dose opioids intake? But good, we've clarified that that's the limitation. Are there any further questions? I think we do have one more question there. Would you consider or recommend use of PROMs or PREMs, Firkin?
Could you elaborate what PREMs are? Sorry, it's the first time I've seen that.
So would you consider
what is PREMs?
Yeah,
patient reported
PREMs.
Sorry, what did it say? Patient reported outcome measures. Oh no, PROMs. What are PREMs?
Patient reported outcome measures.
Oh, so okay, so it's the same thing. Would you recommend using PROMs or PREMs experience measures? Look, I think it is a good way to assess whether patients or how they're feeling following the arthroplasty. At the end of the day, we can assess patients the way they're experiencing their joints, like using Oxford scores following the surgery. There's unfortunately, we can consider using amount of opioid use post-op as an objective measure of whether or not there's actually a proper intervention or it's actually been effective. But I think using Oxford scores post-op to see be able to analyze where there is a difference or a mini clinical difference pre and post-op and comparing between two groups is something that would need to be utilized.
Thanks, Birkin. If there are any other questions, we'll take the questions on board and we'll share it with Firkin for further clarification. We now would like to invite Kimberly Rayner, exercise physiologist, to present her interesting topic on physical care for staff repair. Quite needed. Thanks, Kim.
Thank you. Okay, cool. All right. Hi, everybody. My name is Kimberly Rayner, and I'm an exercise physiologist working at Fairfield Hospital in cardiac rehab. Today, I'm presenting my quality improvement project, Physical Care for Staff Repair. So a bit of background, cardiac rehabilitation seeks to improve the functional capacity, well-being, and health-related quality of life of patients with heart disease. Tai Chi is a traditional Chinese martial art based on gentle body movements accompanied by relaxation and breathing exercises. It is essentially a mind and body exercise. Some of the benefits of Tai Chi include decreased stress, anxiety and depression, improve mood, improve aerobic capacity, increased energy and stamina, increase flexibility, balance and agility, and improve muscle strength and definition. The cardiac rehabilitation team had to offer a simple and safe online class to keep the service running whilst battling the Delta and Omicron outbreaks. After much research on the benefits of Tai Chi on cardiovascular health, classes were implemented online via the PEXIT platform with one instructor, which was myself, and one staff member, which was a nurse, present to monitor patients. Tai Chi can be done in standing or sitting, so it was safe for online rehabilitation. Patients participating in online Tai Chi classes from Fairfield Hospital's cardiac rehabilitation service reported feeling good, enjoyment, decrease in pain, motivated, and relaxed. After the successful implementation of Tai Chi to the cardiac rehabilitation service, it was realized that Tai Chi not only had positive effects on the patient physically, but also mentally. It was then identified that these positive effects could then be replicated to staff who were suffering with increased stress, low mood, depleted energy levels due to understaffing and heavier patient loads caused by the COVID-19 pandemic. The aim was to support staff wellness through providing 15-minute Tai Chi group sessions to help reduce stress, improve mood, increase energy levels, and boost staff morale over a 6-week period. Nature of the problem. So COVID-19 has resulted in an increased demand on the healthcare system. Staff have suffered both mentally and physically due to putting patients first before themselves. 2 studies were reviewed. Stubbs et al. Concluded higher levels of psychological distress were higher among those that were physically inactive. And Teo et al. Concluded perceived stress and job burnout were higher during the pandemic. Extent of the problem. So the study completed by Stubbs et al. Was completed between March 2020 to the end of May 2020 on healthcare workers in a New South Wales hospital. Healthcare workers were asked to rate their general and mental health. In the study, 80.4% rated their general health and mental health as excellent, very good, or good during the height of the pandemic, compared with 92.5% before the pandemic. So that was a decrease in overall ratings of health and mental well-being. Common symptoms of respondents included feeling tired out, nervous, depressed, and everything felt like an effort. Furthermore, 53.1% of respondents reported lower levels of physical activity during the height of the pandemic in 2020. As the pandemic has progressed, the ongoing challenges remain to healthcare workers. The Delta and Omicron waves have seen excessive workloads and staff shortages across New South Wales Health due to an increase in COVID-19 transmissions and restrictions. Implementing a solution. So in collaboration with the staff wellbeing officer and project and business manager, the cardiac rehabilitation team pitched the idea to offer free 15-minute Tai Chi group sessions for all Fairfield Hospital staff 3 times a week for a period of 6 weeks. Approval was formally gained from the General Manager's Unit, and the Tai Chi group sessions were advertised via email to all staff each week with the scheduled times. A COVID plan was devised to ensure the COVID-safe protocols could be followed, and where possible, the activity was undertaken in outdoor space. A variety of time slots were trialled to allow opportunity for inclusion of all workforce at Fairfield Hospital. All participants were asked to complete a pictured and numbered feedback form on their first Tai Chi group session to reflect their experience on how they felt pre and post the group activity. It measured mood, stress, energy levels, whether staff would like further physical-based activities for staff wellness, and an opportunity to leave further comments. Outcomes and evaluations. We had a total of 65 people participate in Tai Chi, with 43 returning for a second session or more. An overwhelming 93% of participants reported having a reduction in stress levels after 15 minutes of Tai Chi. So the average participant stress levels before Tai Chi were rated as a 6. Average participant stress levels after Tai Chi dropped down to a 2. A further 91% of participants reported a positive change in their mood after 15 minutes of Tai Chi. So average participant mood levels before Tai Chi were a 5, and after Tai Chi, they were boosted to an 8. People were feeling a lot happier. An additional 91% of participants reported they felt more energized or benefit after a Tai Chi session. And furthermore, 100% of participants reported wanting to see regular physical activity-based programs being held at Fairfield Hospital. Some of the participant feedback I received was, I attended the Tai Chi and it was great. I felt energized and was ready to start the day. Thank you for running the sessions for us. I was stressed and tired, so this Tai Chi helped a lot to clear my mind. And it was nice to meet up with other staff and do something enjoyable and fun. Things that didn't work so well. So not being able to provide a time to suit everybody. Weather events and not always having access to an indoor venue. The original design of the feedback form was a little confusing for some people, so it required redesigning. Some people felt self-conscious about exercising in public, and many wanted to attend, but due to staffing, it wasn't always possible. Sustaining change. So compelling results can be used to support future physical activities provided by an exercise physiologist within the hospital. We will continue to collaborate with staff wellbeing team for further ideas to help staff wellness and work towards creating regular activity. And the hope is to continue to have a positive impact on staff physical and mental health. Future scope. Create a regular physical activity timetable within Fairfield Hospital to support staff health. Create a new exercise physiologist position on the wellbeing team within the district. Provide different types of physical activities, such as stretching, Pilates, yoga, low to moderate intensity exercise, and walking groups for staff wellness. These activities were actually collected from the data provided on the feedback forms. Provide physical-based activities for certain wards. So I actually had requests from different teams to have private sessions and provide different time slots over the day to allow more people to attend. I just want to acknowledge some people. So my team for the quality project, Joanne Harvey, Nada Badawi, and David Kelly, and some special mentions to Sandra Lombardini for emailing staff 3 times a week for 6 weeks, Ashwini Tajit for looking over the quality project prior to submission, management for the support of the project, and of course, all participants. Do we have any questions?
The great presentations, fantastic effort for the staff, and I'm sure there's a lot of oncoming activities related to this. I've got a couple of questions in there. Do you guys? Okay. Yeah, no, we didn't have any major questions from the attendees. That's it. Thank you. If there's any questions, I'm sure they will get in touch with you. And we hope there's more activities, physical activity options available at Fairfield for staff. It's a great effort. Thank you.
Thank you so much.
I'd now like to invite Ms. Joanne Harvey to present her outcomes of Southeastern Sydney LHD nurse-led cardiac rehabilitation program, uptake and completion rates for 2019. Thanks, Joanne.
Thank you. And Hi, so I'm Joanne and I work at cardiac rehab at Fairfield Hospital, and the project I'm presenting is the outcomes of Southwestern Sydney Local Health District nurse-led cardiac rehab programs. We looked at the uptake and completion rates for 2019, and I'd just like to acknowledge sorry, my notes are.
You're on mute, Joanne.
You're on mute. Unmute yourself.
Oh,
Unmute.
apologies. Am I back?
Yes.
Yeah, I just wanted to acknowledge the Cardiac Ambulatory Services Nurses Working Group that participated in the project and were involved in the preparation of the poster as well. So cardiac rehab is not an admission avoidance program. It's actually secondary prevention. And our focus is looking at patients that have had a recent cardiac event or intervention. Secondary prevention is looking at slowing the disease process and bringing the individual back to their previous health. This is achieved by education and having the individual understand their disease, and for them to learn use strategies in health, their health of their heart, to set achievable goals. And our programs are based on what the client needs, requires, and requests. So the relevance, ischemic heart disease still is the #1 cause of death in Australia. And the World Health Organization recommends that all appropriate cardiac rehab patients should be referred to a program. So we're not a mission prevention program. The evidence suggests that we can actually reduce readmission by 34% and 26% within the first 12 months of the cardiac event. Unfortunately, a lot of studies demonstrate that the referral to the programs is poor, with about 30%. And of that 30%, only about 28% actually take up the programs. So our aim of this project was to compare the uptake and completion rates of the 5 nurse-led cardiac rehab programs in Southwestern Sydney. We benchmarked it against what was available of the national cardiac rehab data. Our method, we did a retrospective audit of all appropriate patients referred to the programs in 2019, which was completed in 2021. Patients' data was de-identified for the purpose of this audit. Data was collected, was validated by the entries in the patient's EMR. A literature review was conducted to benchmark our data with the available published national data. Our definitions, we had a referral pathway and we followed that. Contacted was when the patients were offered the program either by phone or mail. And uptake is when the patients accepted an option of the program. Completion was when there was a negotiated finish between both the participants in the program. Not completed were the patients who dropped out or were too unwell to continue or were carried forward into the program for 2020. Dropout patients were the ones who did not negotiate a finish date and did not respond to attempts, and deaths were excluded. So this is our priority pathway that we work with, and currently there is a state working group working on the priority pathway using our Southwestern Sydney Local Health District CAS pathway as the template. So on that working party, we have representatives from ACRA, our governing body, and ACI, and our community of practice cardiac rehab group. So our results, we had over 3,000 referrals, and they were appropriate referrals. And of those 3,000 referrals, we managed to contact 100% of those patients. So our uptake compared to the national average was good. We had a 65% uptake and 28% was the national average. Where the results are complemented by the fact that we have a good priority pathway and referral system, and with many of the cardiac rehab programs utilising the automated referral process as well. Sorry, my notes have just gone off. Results for completion of the program. We had 91% complete compared to 59% complete. And this has a lot to do, it's reflected that our programs use our resources and requirements at each facility. We know our cohort of patients, and we offer a great range of options to our patients. So we've got a robust referral system, flexibility, we're adaptable, and also all staff have a cardiac background, and some of us are internationally credentialed for cardiac rehab. The types of things that we offer in our program: we have outpatient options, we have inpatient options, community-based options, home-based options, and virtual telehealth options. So we try to cover something for everybody, and some patients will take a little bit of that, or they will take a few of those different options depending on their requirements. It's also best practice to help have their patient choose and help design their programs. Over the last 20 years, we have looked at many different options and trialed many different things. And so I've put the examples up in the diver diagram. Was one of the best ways to show what we've tried over the years. And many of the options that we have trialed are still standing. Some of the things that we have done that we may need revisiting are things like the CardiHab app. That was one of the first apps available, and it was before pandemic and people weren't used to using telehealth. So that may be something we will look at the future going back to. We've trialled community-centred exercise groups and educations in the past, and once we lost hospital transport and our patient cohorts started to become more high risk, it was unsuitable, and that wasn't sustained. We've also trialled bilingual programs. There was poor uptake, mainly because there was delay in commencing, and it was also not sustainable for staffing. So on the whole, we've done quite well compared to the national data with little resources. And in the future, we would like to revisit of how we've gone. After COVID, things have been difficult, and we've used every type of option to run our programs to maintain our future. So we're looking forward to next year when we get back to our new normal. Thank you.
Thanks, Joanne. That was a great presentation and fantastic use of science improvement strategies to improve patient care. So well done. And the flexibility of your program is probably the major reason for the success. I think we do have a question there, Joanne. So what's the participation rate for the CALD community patients?
Pardon?
What's the participation rate for the CALD community patients?
So we have so Fairfield has a CALD community of 56%, And we run block bookings for our COG community. With our two main languages, we have weekly, fortnightly booking of Arabic, Assyrian, and of Vietnamese. That they're probably represented at about 50% of our patients.
Fantastic. That's great. If there's no further questions, we will move on to the next speaker. Thanks, Joanne.
Thank you.
We've got our next speaker on site. Dr. Gayatri Majumdar is going to talk about remote management of COVID and COVID-19 in residential aged care facilities. Thanks, Gayatri.
Thank you, Ram. Hello, everyone. Just wait. So it's an absolute privilege to be presenting amongst the brilliant presentations that has happened today. My presentation is about our service, the Geriatric Client Support Service, and about our role during the Omicron outbreak in November to January this year. So next slide, please. So our team has, next slide, please. So yeah, that's it. And just the next slide. And then we can go to the next slide. Yeah. So our service was initially established in 2018 with one FTE geriatrician. And during COVID, it did get augmented with nursing cover, locum RMO, and a rehab registrar, which is not really consistent all the time. We try to provide both acute and subacute service in a remote setting to nursing homes in the Fairfield area. We try to do most of our reviews via telehealth and then triage them and try to see the acute referrals within 4 hours of referral, with the main objective of trying to keep the patients in the nursing home and avoid a hospital presentation. And that is a big job because we have got 16 nursing homes. I think Fairfield is an area where we have the maximum nursing homes in the whole of the district, and it has got more than 1,700 residents in that area. Next slide, please. Thank you. So during this Omicron outbreak, we tried to see if we can keep the patients of acute COVID patients in the nursing homes and treat them in the nursing home. And this has not been really trialed in the community setting. This is back in January when everyone was scared of COVID, and including the nursing homes, and there was a lot of paranoia and panic involved in managing them in the community. So we did try to see what we could do to try to help the RACF to manage them in the nursing home, and also to see whether we can actually do any substantial work to try and avoid hospital presentations during that time, because we thought that the hospitals will overflow if the 1,700 residents from the nursing homes started presenting in the hospital. So the nature of the problem was it's very complex. During Omicron, there was a lot of pressure from the nursing homes to send them because they did not want to keep them in the nursing home because they were worried about the infection risk. And the hospital didn't want all the patients coming in because of obviously their bed situation. And so to provide a service in between where we can sort of still provide the effective service that the patient needs in the facility, and offloading the hospital of the pressure patient load, that was the biggest issue that we had to face. And no one had treated acute patients of COVID, which actually required a hospital admission out of hospital environment at the time. And we did not have any data that we could look into and say that it can be effectively managed in the community with people with acute COVID that wants to come to hospital. There's no evidence or research that we can fall back. We could fall back and say, no, we can effectively treat these patients in the community and they don't have to come in. So it was sort of how we thought that we will start doing it, and we'll see how the effect is. And before Omicron, when Australia never saw a big outbreak with Alpha and Delta. So Omicron was the first real COVID outbreak that we started seeing in our at least Southwest Area Health Network. Next, thank you so much. So during the whole process, we started another ward which was an acute ward, was an acute virtual ward, and we called it our COVID ward. It was a virtual bed board that we had and that we used as our inpatients. We tried to manage them as per the updated, guidelines that we had at that time, and that included corticosteroids, antibiotics, oxygen, and DVT. Antivirals was not really implemented around in January at that time in the community setting. The oral antivirals were not really out, and we tried to sort of provide a patient-centered care according to their advanced care directives. And also, depending on what the family conference update, we did a huge number of family conferences, talking to the family, talking to the relatives, talking to the patient, and that towards via telehealth. And as my previous speaker, Joe, has said, it's like 50% cold community, and to manage the concept of treating out of hospital to the cold community was also a big challenge. We did get a lot of referrals from not just the nursing homes, but also we got referrals from GPs, ambulance officials, the EOCs, and even the emergency person who would look at the bed boards. And we used to look at the hospital sort of emergency ambulance board all the time and try to pick the patients from there. And we did not, during that period, we did not only manage COVID patients, we continued to do our normal bread and butter role, which was managing the non-COVID patients who were also sick and wanted to come to hospital. And on top of those two roles, managing the patients of COVID and non-COVID patients, we also provided support to the nursing home and tried to improve their capacity of managing outbreaks. So we did integrated care to the next level. We did regular meetings with nursing homes on outbreaks. We joined the outbreak management teams. We joined the EOCs, and it was like a huge coordinated effort between the hospital, the district, the public health, the ministry. So we all sort of got together and did regular meetings with the nursing homes and to help improve their capacity in managing an outbreak. So in looking at our outcomes, we looked at the major outcome was around, the outbreak was in January. And at that time, there was 59 patients from the Fairfield nursing homes that wanted a hospital admission. And GFS treated 21 of them out of hospital, and the rest 38 presented to hospital. And that's a 35.5% of patients that seeking hospital admissions were treated out of hospital. Otherwise, this would be in an inpatient in the hospital. And this is within a month in the month of January. Of the patients that we managed in the community, the 21 patients, 15 were palliated, and the rest 6 did receive active treatment in the nursing home with previous mentioned treatment. We also categorized them as acute, like 16 were acute as they had within 14 days of diagnosis with COVID, and 5 were complications due to long-term prolonged COVID with hypoactive delirium, dehydration, poor oral intake. And of the patient that was admitted to our GFS COVID ward, 12 died in the nursing home, and 3 were referred. We had to send them to the hospital, and 6 were treated successfully in the nursing home. Next slide, please. Thank you. So this basically is just a simple outbreak of, we did manage to discharge 43% of the patients to our service without any complications, and 57% of the people were palliated, and they end up dying in the community. And that was also a huge task, because with a COVID patient that were palliated, it took a lot of support from our team as well as the palliative care team in providing the appropriate palliative care to the dying COVID patient in the community. This was our second objective. We did not want to lose out our normal bread and butter role while managing the COVID patients. So our still main objective goal was to keep patients out of hospital. And we still had non-COVID patients to look after, not just the COVID ones. So this was the data of Fairfield Hospital presentations and our activity over 3 years period from November to January. And if you look at the first bar diagram, that's the Fairfield ED presentations. And over the span of 3 years, compared from November to January 2019-20 to 2020-21, the ED presentations have dropped down from 335 to 156. That's a 54.5% reduction in presentation. And our activity has increased significantly as well. Next slide, please. So in terms of innovation and originality, I think we did prove that integrated care can be taken out of hospital in an unprecedented way. We did not just integrate, normally we are just more involved in hospital activities and maybe outpatient clinics, but we did integrated care to the level of the Commonwealth, the public health network, the emergency outbreak teams, the ambulance services, and it was a massive coordinated effort to just improve the capacity of nursing homes and deal with their paranoia and their fear of managing COVID patients in the nursing home. And we see the outcome now. Now, nursing homes are very confident of managing patients with COVID in their own facility. And it was a huge integrated care that was done with a lot of stakeholders, and we were one of them. And also the fact that we have proven that we can treat acute COVID-19 patients who wanted hospital admission in the community successfully. And other outreach teams can probably do the same in other health networks. I think that's it. That's my references. Thank you.
Thanks, Gayatri.
No worries.
Wonderful effort and great presentation. We do have a question in there. Is there an active community participation in planning and design work?
Yeah, there is. The community consumer participation comes as the part of the nursing home manager, the nursing home clinical coordinator, that we always involved in the planning meetings. We do weekly meetings. During the COVID outbreak, we used to do weekly meetings with all the nursing homes, and we used to come together and we would talk about what concerns they have, what help do they need from the hospital, what help do they need from the district, and we tried to meet their needs. And in terms of consumer participation, when we were treating patients and we're seeing patients, we do a huge amount of advanced care directives, we do a huge amount of family conferences, and we take the patient's wishes on board when we're treating them. So if you want to treat a person, and we always ask them, if they think this, we try to convince them about our capacity to treat them in the nursing home. But if they want the patient to be transferred despite our interaction, we respect their wishes and we send the patient to hospital. So at the end, it is still a lot of community involvement that we do.
I've got a question, Gayatri. Was there a lot of education involved with this, and how did you deliver the education for this RSCF community?
So during the peak of the Omicron outbreak, that is the maximum amount of education that happens. We used to do weekly RSCF meetings, and that would be included the community and the care managers of 16 nursing homes. With our team, there was a public health team, public health medical officer, and the public health team, there was a Commonwealth, then there was a representative from the district, and we all sit together and try to educate them of what to expect, how to deal with PPE management, how to get funding and how to get the antivirals, how to, so we did weekly meetings with them.
Thank you.
Thank you.
I'd now like to invite Ms. Thomas Wang to present his topic on shoulder replacement group education classes. Thomas. Thank you.
All right. Thank you again for the opportunity to present. Good afternoon, everyone. My name is Thomas. So I'm currently the acting senior physiotherapist at the Whitlam Joints Replacement Centre at Fairfield Hospital. So I'll be presenting a quality improvement project that myself and my colleague Katie had done earlier this year and the results of it. Yeah. So a bit of background. So our Fairfield Orthopedic Hip and Knee Service is run at the Whitlam Joint Replacement Centre at Fairfield Hospital. So our team involves 1.7 FTE physiotherapy, 1.0 clinical nurse consultant, and 2 admin officers. So part of our model is based on the osteoarthritis chronic care program that's run by the ACI. And in terms of physio, we're strongly involved in management of patients on the waiting list for elective hip and knee arthroplasty. So a large proportion of our patients are mainly patients who've been referred have been recommended for surgery from the orthopedic specialist, and they get put on our waiting list. So part of our role is, whilst they're on the waiting list for 12 months, we see them on a regular basis to provide education, whether that's just on the optimization of their osteoarthritis and maximize their function before going into surgery. So this predominantly includes both physical preparation, so whether it's getting their muscle strength, improving their function, or just mentally preparing themselves for surgery as well. Part of our role also includes facilitating that early discharge planning to optimize the post-op recovery. So from our service at the moment, we also receive recommendation for admission forms for patients undergoing total shoulder arthroplasties. Now, over the last 10 to 15 years in particular, the number of shoulder arthroplasties have beginning to increase quite dramatically. So there was a study in 2020 that looked at the data from 2017, and the projection rates showed that by 2025, the incidence would increase by 67%, and at a greater rate than our current hip and knee arthroplasties. Now, at the moment, in terms of our current model and process, so before I rotated into this role, physiotherapy was not involved in management of these patients. So these patients would have an initial assessment from the nurse that would do a medical screening, and then wait 12 months until they get called up into the pre-admission clinic and then booked in for surgery. So having done junior rotations before in both the inpatient and outpatient orthopedic setting, and also discussing with my colleagues, we identified a number of gaps in our service. So on the wards, when we see these patients after surgery acutely, there were concerns about whether these patients were able to retain the information that was provided because they were quite drowsy after the surgery. And a lot of times when they've been discharged, they've been contacting our department on a number of occasions, trying to clarify the information. So these patients weren't able to retain the information and quite anxious about where to go on from here and what to do next. So there was a number of increased time and resources spent to address these concerns and to spend time in speaking to these patients. Also, in terms of the rehab post-op as well, in the outpatient departments, patients often had unrealistic expectations of their surgery. So whether it was from a recovery point of view in terms of the pain, the range of motion, or returning to specific activities and sports, patients often had unrealistic expectations that really impacted on their recovery, compliance, and the overall satisfaction rates. Yeah. So after discussing with my colleague at that time, we were looking into, can we see these patients in a pre-op setting? Given we have our joint replacement clinic, can these patients, be given that education before going into surgery to improve on the outcomes? So part of our intervention looked at initially what was the patient's current satisfaction of their education. Are they receiving education? Do they know what to do? And what is the level of confidence going into surgery? So these were the set goals at that time, and a lot of it was trying to drill in, can we improve patient outcomes by improving patient education and confidence? So before we did commence this project, we did look at the literature at that time. So recent evidence suggesting the fact that if we can address these preoperative expectations, that would impact on the patient satisfactions and outcomes afterwards. So in particular with total shoulder arthroplasties, compared to any other upper limb or lower limb extremity procedures, they had the lowest preoperative expectations and the lowest met expectations as well after surgery. So again, this shows the importance of having that conversation and discussion with the patient, making sure they have that education that they receive, and so that they can come into surgery with the best information that they have. Now, interestingly, in the last dot point there, even with the patient counselling with surgeons, that wasn't enough to alter their expectations. So following the initial surgeon consult, they showed that there was a poor recall of the risks, benefits, and complications after surgery. And they suggested solutions in terms of group settings, using multimedia tools such as patient handouts, videos to try to enhance that retention and comprehension of their education. Yeah. So this project started in February, so late February, early March, where we looked at our patients on the waiting list. So we had 41 at that time that were ready for care, whereas there were still a number of patients that weren't ready, that weren't appropriate for this project. So 3 patients were non-English speaking, so they weren't contacted because they weren't suitable for this project that we were doing. 2 didn't answer the phone. 1 was undergoing rehab inpatient at that time, and 2 declined to do the survey. Now, we had done 33 surveys at that time that was done over the phone, so it took about 5 minutes. And following the phone call, we invited them into the education class that we commenced to see if they were ready, wanted to go or not. So 76% of that population were agreeable. And the main reasons why that they didn't attend was, number 1, they felt like they're already confident in the knowledge. Number 2, they were scared and they didn't want to know anything more. So they didn't want to be scared by the surgery, surprisingly. And the other reasons was due to transport and work commitments. So we had a total of 20 patients for this project and 5 classes completed over that period of time. Yep. So patients were sent out an invite once they were agreeable. We did a group presentation at our Whitlam Joint Centre. So that was both about the shoulder arthritis as well as expectations and management post-operatively. We also gave each patient a patient booklet so that they could consolidate their learning afterwards, an opportunity for questions and answers, and a satisfaction questionnaire was completed at the end. Yeah. So in terms of our outcome measures, so our primary outcome measures were looking into patient self-reported scale. So what is the current satisfaction of the education they receive? What is the overall confidence in the knowledge and the confidence in it being able to manage post-operatively? So we asked these questions in that initial survey and also asked it following the education to see if there was a difference. Secondary outcomes involved patients' perceived expectations, pain and disability, as well as looking into their physical outcomes as well. So with this project, we didn't have any database about these patients at all. So we wanted to see what their level of disability was, what they thought their pain, what level was, and to see, so we have at least an idea of what these patients were at going into surgery. So these were the initial results. So question 1 looked into the satisfaction rate. So you can see that improvement from a mean of 4.93 to a 9.10. Yep. Question 2 looked at the confidence in the knowledge of the surgery and the expected outcome. So this again improved from a mean of 5.45 from a scale of 0 to 10 to an 8.7. Yeah, and the last one in terms of the scale was the overall confidence. Now, out of all questions, this one improved the least, and it's likely due to the fact that patients thought that the recovery was going to be easy and very straightforward. So having given that education about the immobilization phase, they can't drive, they can't use their arm for a period of time. Maybe that opened up new avenues in the fact that maybe they needed more planning and preparation for their surgery. So that's why the improvements wasn't as great, but overall it still improved. Yeah. The next few questions we did wanted to look at specific domains in terms of the post-op management. Do these patients know what happens afterwards and what were the expectations afterwards? So we did a graph for each question, so pre and post intervention, and we really highlighted the unsure category. So in red, you can see that a large proportion of these patients were quite unsure about this, the immobilization phase. So post-intervention, we were able to eliminate that and increase the amount of correct responses. Yeah. Similar in terms of returning to driving. Now, most of our population were a lot older age, so it wasn't relevant to them, but still a lot of people still were unsure about when could they return to driving. And following the intervention, again, we were able to reduce the uncertainty and increase the correct responses. Yeah. In terms of recovery, so this was quite alarming. So the fact that patients were initially unsure or thought the recovery was at a shorter period of time. So with the education, we're able to address that and have that realistic expectation of the recovery. Yeah. Similar, once they understood the immobilization phase, they understood that they couldn't move their shoulder for 2 weeks after surgery. So again, we're able to improve that education. So the next one looked at the movement overhead. And again, this was one that was really difficult to address in the post-op phase because they had that expectation, but we're able to address that in the pre-op situation. Yep. Similarly, in terms of lifting overhead, again, we're able to remove that uncertainty component. Stiffness as well. So given that they knew they were wearing a shoulder sling, they knew that they weren't able to move their shoulder after surgery and potentially develop stiffness. Again, the next one looked at being pain-free immediately, and we were able to increase the number of no responses. This was quite alarming. So prior to signing the admission forms and the education class, there was a large component of patients that have never seen physiotherapy or never received any physiotherapy treatment. So according to the guidelines, we really want to improve their conservative management first, and that involves getting physiotherapy advice and input before considering surgery. This was the overall feedback. So I think the last real dot point really is a patient who attended the class, reviewed the content, and then came back a couple of weeks after, and having understood the rehab process, understood the outcomes, he actually wanted to be waitlist removed after receiving that education. So I guess it goes to show that the importance and the power of education to improve patient outcomes. So at the moment, he's just managing his arthritis conservatively and not considering surgery at this stage. Yeah, we'll just probably skip the next few slides. Yeah, and we'll just go on to the last part. So in summary, we're able to improve overall satisfaction rates and their confidence in the ability to manage after surgery. And following the education, we're able to reduce the amount of uncertainty as well. Yeah. Thank you.
Thanks, Thomas. That was the fantastic initiative and great learning opportunity for patients going to shoulder surgeries. I don't think we have any questions online. Thanks for your presentation.
Yeah, all good.
I'm going to invite the next speaker. Our next speaker is Dr. Lian Tian, who is one of our ICU anesthetic trainees. She's going to present on reducing perioperative hypothermia at Fairfield Hospital, a quality improvement project. Thanks, Lian.
Thank you. I'll just share my screen.
That'll be great.
Can you all see my screen?
Yes.
Yeah, okay, great, perfect. Hi everyone, thanks for having me. My presentation is on reducing perioperative hypothermia, a QI project I conducted with Lindani and Seba, two of the theatre nurses at Fairfield. So just a little bit of background, the Australian Council on Healthcare Standards performs audits on all the hospitals in New South Wales on 5 clinical indicators in anaesthesia and perioperative care. These include post-operative nausea and vomiting, respiratory distress, severe pain, hypothermia, prolonged stay and recovery. So the good news is Fairfield is performing better than its peer hospitals in having lower incidences of nausea and vomiting, severe pain and a prolonged stay. However, for hypothermia, we're performing worse. So according to the audit, which is conducted every 6 monthly, for the first half of 2021, 9.5% of our patients, which were 320 out of 3,300, were hypothermic, defined as a temperature of less than 36 degrees. And this was in recovery. And compared to peer hospitals, of which only 5.6% of patients were cold, and compared to general hospitals were only 1.4% of patients. So why do we care about hypothermia? It's a very well-known and frequent phenomenon of anesthesia, and it has some serious adverse outcomes. Predominantly, these are cardiac events, which could include risk of MI, cardiac arrest, and particularly in patients who are already high risk. It also increases post-operative wound infections, disrupts platelet function, causing increased risk of bleeding and increased need for blood transfusions, increased morbidity and length of hospital stay, and increases death. Warming also adds to a patient's comfort and their theatre experience. So our project, we have the goal to reduce the incidence of perioperative hypothermia at Fairfield. We had a multi-pronged method, which was to increase awareness of the importance of hypothermia amongst theatre staff by providing education, reminders during handover, team huddles, and staff questionnaires. We collaborated, working with the nursing staff, nursing educator, and data officers. We wanted to increase monitoring as well, so throughout the perioperative process instead of just recovery. We wanted to improve access to measuring and provide a bit more reminding. So our education, we provided in-services to our nursing staff in theatres and in day only, and we put posters throughout OT. This is an example of slides of education kind of presentation gave. Monitoring, so monitoring, I guess it was just an extra check to remember to check the temperature and intervene if it was cold. This also, we also tried to kind of engage with daily reminders and morning huddles and handover. These are a couple of examples of the physical education pamphlets we put in the tea room and in change rooms, just everywhere. So on the left-hand side. And then on the right-hand side, you can see this is kind of an example of a monitoring chart. So each patient got one of these forms in day only, and they had their temperature measured in day only, or pre-op ward or ED. In the anaesthetic bay, intra-op whilst they were in theatres receiving their surgery, in recovery, and then post-op ward. And then any interventions there. And that wasn't really to check whether or not any interventions were conducted. It was, again, another reminder. So what were our findings? So during January and February in 2022, so this was pre our interventions, there were 13.2% of patients who were hypothermic. We started our interventions in March, and in March and April of 2022, we found that patients were, 11.5% of patients were hypothermic. I think that it's interesting to note that the amount of surgeries actually doubled during this time. However, the percentage of patients who were cold dropped. And this was during COVID, so it was during reduced operating cases. So according to the chi-square test of whether or not a patient was, it was a statistically significant result, it was not. However, the results appear promising, especially because of kind of quite recent interventions, and with the increase in surgical activity and increased patients, we were still lowering the percentage of hypothermia. We also demonstrated an improvement in our questionnaires and in the kind of answers that the nursing staff were providing. So our other findings were, if we broke down the temperatures a little bit more, the mean temperature in pre-op ward was 36.4 degrees. And the mean temperature in recovery was 36.2. This suggests that patients could be slightly cold prior to their arrival in theatres, which emphasised the importance of providing education in day only as well. Ongoing improvements, we provided further education within services at day only in theatre staff, with new staff and junior staff. Fluid warming, initially Fairfield was there was an understanding that across Southwest Sydney, we were not warming fluids. However, I think with the results of this audit, we have since started warmed fluids, and we provided ongoing in-services and education and considering of laparoscopic specific bear huggers. So what next? So we are going to monitor the ACHS results and repeat the audit with these interventions in place, which is an ongoing process, because we still do have 11% as of March and April of patients who are hypothermic, which is higher than our peer hospital. That's it. Any questions?
Thanks, Leanne, for the engaging presentation. And I've got a team who's going to monitor this and audit this ongoing, which is great. So There's no questions online. Unless it's on. Yeah. I'd now like to invite Prof. Loki to give a closing address for this session, please. Thanks, Prof.
Thank you very much. So listen, thank you very much for inviting me to close this session. I would like to, first of all, tell you that I've enjoyed listening to the research that was presented, and I want to thank all of the presenters, and in particular, all of the staff at Fairfield Hospital who work at Fairfield clinically and administratively and who have contributed to this day. I'd like to thank Seema for the work that she's done and for her excellent presentation. Justine Naylor, thank you very much, Justine. Paul Crow, the General Manager. Harry Doan, the Director of Medical Services. Sharon May, the Director of Nursing, thank you very much for the work you do at Fairfield and for supporting research. Courtney McDonald, the Operational Nurse Manager, and the heads of all the various departments across the Fairfield Hospital, which really adds to the concept of embedding research in clinical practice. I'd like to thank Anna Marie D'Souza, Rachel and Morale from the Research Directorate for supporting this symposium. And I'd like to thank the staff at the Ingham Institute who have also supported this project. I've been asked to invite you to tune in at our next seminar in the online series, which is going to be on the 28th of February 2023, and it's a good one. The topic is Consumer Research Committee Showcase. Very few LHDs, in fact, have got a lens to consumers and their cooperation and productivity within the LHD's research. And I'd like to congratulate our organizers for organizing a Consumer Research Committee Showcase. So thank you very much, all of you, and I look forward to our next showcase in 2023. And can I wish all of you a very happy and holy Christmas. Thank you.